Welcome everyone. This is Dr. Sharad Jaitly from New York. Here I am on my MuniMeterHealth.com, my website, which is dedicated to teach and help you learn as we go along all about heart and its illnesses, as well as how to manage and keep the heart fit. So here's a new software program that we have incorporated only recently, as you've seen in the last couple of videos. We have just started to adapt and adopt into this new website. Software rather. So let's see where we are today with what is a stress test. So basically I'd like to tell you fundamentals of a stress test first, what a stress test should be and how it's performed. Two, how do you make an interpretation? What are the key things that you want to make an interpretation from? And then how do you write a report? So the whole talk will be divided more or less in three parts or so. So as we go along, let's start understanding as to how we perform this test. So basically we are looking at, as I said, a treadmill test that's being performed by the individual here. You have an incline and you have a set speed. So the treadmill stress test is being performed. Every stage is roughly about 3 minutes. It's programmed to go higher on incline and higher on speed, and therefore now this is stage 2. There's another 3 minutes added to it. Then you have another stage 3 here where another 3 minutes is added, and then so on and so forth. And stage 4, most patients don't get there, but if they do, obviously they're in great shape. So just so that you know, normally most marathoners, I tend to give them a little warm-up time and immediately get them to stage 4 and let them run on that. So essentially you want to have the person walk as much as possible. Now, there are certain prerequisites for the patient. Obviously, when he or she is arriving at your office, should be nil orally. In other words, should not have had any meal at least for 2.5 hours. Because remember, an hour and a half, 2 hours is your gastric emptying time. So to avoid any nausea, vomiting, and plus also redistribution of blood flow into the splanchnic system, you really want to have that patient fasting for about 2.5, 3 hours. So this way you can perform the test well, number one. Number two, obviously the patient has to perform maximally, so therefore should be in a comfortable attire, preferably in shorts, etc., if you can, and of course with a very light shirt, etc. So this way person is maybe sweaty, etc., but you want to be sure that the person is not exercising and very uncomfortable either. So you want to have the maximum support for the patient. Two, you want to have the patient on an empty stomach and then perform maximally. Now, how do you define the maximum heart rate? Well, first of all, you'll be looking at the following parameters. You'll be looking at the heart rate, you'll be looking at the blood pressure, and you'll be obviously looking at the ECG here. So these are some of the parameters that people tend to follow. Now, obviously, you tend to follow heart rate and say, look, if the heart rate response was normal or it was exaggerated, like the heart rate really went high, so that is abnormal, or the heart rate response was blunted. So if you have a blunted response, then you define that as well. That means the heart rate failed to rise during the change of stages as we went on from incline to the speed. You can follow Bruce protocol, which I think is the most commonly followed protocol the world over in most stress labs. But then you could also follow Cornell protocol, which is very common, and it's a 2-minute stage, and then there are other protocols you can follow, or you can just do your own modified Bruce, especially for elderly people, which I like to do past the age of 80, 85, unless they're really, really in good 80, 85-year-old shapes. But generally, I think past the age of 75, 80, you can do a modified Bruce. Having said that, so these are the parameters: heart rate, blood pressure, ECG, and then of course the symptoms. Very important. You follow the symptoms too. You like to see if the patient's starting to develop any chest pains, because ultimately the patient is referred from an internist and now is in your lab. You certainly want to elicit those symptoms the patient presented originally for. Is there any shortness of breath? You need to see significant shortness of breath. Most people will get short of breath when they walk or run after 6-9 minutes, so that's expected. But if it is unusual shortness of breath that occurs, say stage 1, and the person is now really, really making big efforts to take deep breaths, etc., then you know that this person is more moderately or severely short of breath and you got to stop the test. So the symptoms may be the reason why the test could be limited. ECG changes could be the reason why the test is limited or stopped. terminated rather, I hate using that word. Blood pressure response, that could be again normal response. It could be an exaggerated response, just like your heart rate, or it could be a blunted response. Now, blunted and exaggerated response will also prohibit the test from going any further into the next stage. So you have to elicit all these things very carefully. Remember, this person is when he's exercising, you have this monitor hooked up with all the EKGs going here into the monitor, etc. And then you have all these leads attached to the person. So you're checking the heart rate, you're checking the blood pressure every 2-3 minutes, at least once per stage, maybe more often. And then, of course, the ECG monitoring is continuously being done. Why do you do the ECGs? Well, obviously, you want to know the ST changes that they were to develop in any of the 12 leads. Then you want to see also if there's an arrhythmia that's developing. And what are the commonest arrhythmias? You'll see a lot of APCs. You may see a lot of VPCs. If they're isolated APCs and VPCs, you can live with it and continue with the stress test. It's not a big deal. But the fact is that if they're occurring in bigeminy, trigeminy, couplets, those are the VPCs will make that could be another reason why the test could be terminated or stopped. Okay, rather let's use the word stopped. So these are some of the reasons why the test could be limited based on what we see on the ECG, the heart rate, the blood pressure, and the symptoms-wise. Having seen these interpretations, so what is a stress test? We have understood. How do you prepare the patient for the test to come in? We have understood. We have seen the interpretation of the test based on these parameters that you normally like to follow, and then try to elicit these symptoms. Now, very importantly, ST changes, you have to have at least more than 1 millimeter in 2 to 3 consecutive leads. Then you call that test positive, remember. Otherwise, you may not call this test positive, and you try to elicit at least 1 millimeter and above to make that test interpretable. Because remember, if you're just doing plus minus 1 millimeter, then again the test will be non-diagnostic. Now, in my practice of my 35-40 years of cardiology, my non-diagnostic report rate was about 5 to 7% only. And I really advise to all my trainee fellows where I was directing the programs, I always advise them, I said, look, try to elicit more than 1 millimeter if you can. Otherwise, if you're here, then you're again lost. You're back to square one where you started and say, look, I don't know what this test is like. So here the patient toil, you spent all your time, and next thing is you don't have an answer for that person, and then now the test goes back into the hands of the internist, who referred, and says, I didn't even get an answer from the doctor. So it's very, very important. Try to give an answer, whether it's a negative answer, whether it's a positive answer, but try to shy away and keep less than 5% of your testings annually to be non-diagnostics for any reason. But otherwise, if you have too high a non-diagnostic value within your labs, then your lab is not performing too well. That's how I see it from quality standpoint. So I think it's very, very important that we understand that either try to hedge towards saying negative a test or a positive test, depending upon what you see on the ST segment changes, what you see on the heart rate response, what you see in the blood pressure response, and then of course the symptoms correlation is very, very important. Now, how do you write a report? Well, number one, you'll say whether the patient exercised to the ability of an average age. Now, patient say, for instance, now the magic number here is, remember, 220 minus the age. Now, that'll be your maximum heart rate. It's very important to understand that. Why? Because once you know your heart rate is, say 180, then you know exactly how the person is performing. So 220 minus the age, say the age is 40, and then obviously the heart rate is about 180. So maximum heart rate can be about 180 for a 40-year-old individual, and then you stop the test. Then you say maximal heart rate achieved, test was limited by the maximum response of the heart rate, number one. Two, you will say the exercise capacity was average, below average, or, so you say the exercise capacity, very important. Why the test was stopped, the first reason. So test stopping or the limiting of the test, the limitation of the test, either because of the exaggerated response, the blood pressure response, or the ECG response, or the symptom response. So you have to define that. Show the exercise capacity on that individual. Why? Because you need to say whether it's below average, it's average, or it's above average. Now, three, you'd like to see and define how many METs if you can, because many times now the monitor itself will define 6 METs, 10 METs, 15 METs, etc., depending upon the exercise capacity that the person has achieved. Thirdly, you'll define what the STT changes are on the EKG. Now, if ST changes are more than 1 millimeter, like I said, then you say it's a positive for exercise-induced ischemia, okay? Because that's what you did. You tried to induce ischemia by exercise, not by anything else, by exercise. So say positive for exercise-induced ischemia, or you'll say it's negative for exercise-induced ischemia if there was less than 1 millimeter change noticed on any of the, or the changes did not occur at all. Now, as I said, very rarely you'll write, like less than 5%, a non-diagnostic report and say, look, this person had a non-diagnostic equivocal response on an ECG. So in a nutshell, all of these parameters are taken into account. My whole objective of doing this quick short video is to prepare you for the exams, put you into the stress labs, say right on day one when you start, you have the heads up, and this way you can really ascertain as to what you're looking for and what you're getting and how you're reporting. And this way, you know, it becomes a lot easier for the entire system to work more efficiently and more conclusively, because that's the whole idea of training within cardiology. And I've always felt in my training years, I know my attendings, my mentors, they're extremely busy. But then at the same time, we did not have these means of understanding and reading together like we are doing it now. So you ended up reading off the textbooks, trying to sort of come out with a way how you want to report. Now, everybody likes to report it differently, but this is the most acceptable way of streamlining the entire report. So this way an interpretation is offered to the internist and ultimately to the person who is coming and getting the test, because he or she likes to benefit and wants to know whether the test was positive or negative. And if you tell the person, well, the patient was the test was non-diagnostic, we don't have any answer to this, you're not getting anywhere. You're still at square one. One, for the physician who referred you, two, for the patient, and three, for your own lab, for yourself, that you're still in a quandary how to manage this patient. So all of these things, and again, we'll discuss how to manage these patients, whether they are positive or negative, on a different video, because that's beyond our video capacity here. I thank you for your interest, for watching MuniMeterHealth.com. Fellows, residents, students, please spread the word and tell them that there is a doctor who is there to teach you and go along with you to help you learn and understand every step of the way how cardiology should be taught. I really aspire to see how best I can convert you into the best of the best fellows, and of course, if you're fellows, how best you can become a good cardiologist and practice the world over. Do write me your comments, and I'll be looking forward to seeing some comments from you. Okay, thank you for watching MuniMeterHealth.com. Until then, so long.